all of our programs end up there. And you can listen to us while you're driving the car, maybe learn something in the process. So that's for that. So we're going to get started on the ABCs of ABGs. Now, this is a fairly rudimentary, basic kind of talk that I'm going to do today, but this recent COVID experience has taught me that there's several people, even experienced perfusionists, that maybe could use a little bit of extra
little refresher,
on ABGs and what they are. A lot of the work that I put together here comes from Dr. Paula Zanninger with her excellent review that she did, ABG Interpretation, and some of the quizzes that I have afterwards come from Lewis Potter, also an ABG Interpretation resource that exists on the web. So there's a lot of resources, a tremendous number in textbooks and different publications that exist that we can use to learn more about blood gases and what they really mean. So let's go ahead and get started. This is more for perfusion, but there's obviously some things that we spend a lot of time in the ICU that may be more germane to there. Very important for us to understand reference ranges. The normal pH runs between 7.35 and 7.45. PaCO2 runs between 35.2 and 45. And of course, on the left side, I have it in kilopascals, and on the right, we have it in millimeters of mercury in order to accommodate our European and Asiatic colleagues that may use kPa versus millimeters of mercury. PaO2 runs between 82.5 and 97.5, and that would be on room air. Bicarb normally is between 22 and 26 milliequivalents per liter, and the base excess runs between -2 and +2 millimoles per liter. And something that I think it may be very helpful for people to realize is, let's just take a pH of 7.40. 7.40 and a PCO2 of 40, okay? That is, in terms of acid base, when you're trying to evaluate, the same as saying 7.35 and 45. That's a balanced equation, for lack of a better way to describe it, which would be the same as 7.45 and 35. So your pH and your PCO2 are tremendously interrelated with each other. And that's important to remember, and you'll see as we go a little bit further on in this. So before getting stuck on details of any blood gas analysis, it's really important to look at the actual patient and their current clinical status, as this provides essential context, and context is extremely important when you're reviewing ABG results. And below you're going to see a couple of examples that demonstrate how context is important. So a normal PaO2 in a patient on high flow oxygen will say, well, it may be a normal PaO2, but the condition is very abnormal because one would expect the PaO2 to be extremely high with that kind of oxygen therapy. So just because the PaO2 of a blood gas you get says 108 or 120, maybe even 150, you have to look at the context, what is going on with that patient at the time that blood gas was drawn, and what should that number be under normal circumstances. A very low PaO2, on the other hand, in a patient who is doing very well, there are no issues, is not, patient's not short of breath, Patient has normal O2 saturations on their pulse ox. Well, it's more than likely going to be a venous sample.
Yes.
You have to look at the whole picture and not overreact to something. But you also have to see these clues, not just in that particular vacuum, but you draw a blood gas. Things aren't really looking good. You look at it and the color doesn't look quite right. It looks really dark. Well, you have to ask yourself in that circumstance, is the patient's hemoglobin very, very high? Because a lot of times a very high crit will give you a darker looking sample for the same saturation. Whereas you draw it and it looks very, very, very bright, even though your pulse ox is reading low, and you're like, man, that looks pretty red, but then you hold it up to a light source and you see that you can almost see through it, you're likely looking at a very low hematocrit or hemoglobin. So you have to look at everything in totality and never just one number. Your first question whenever looking at a blood gas should always be, is the patient hypoxic? And because it's obvious that hypoxemia is the most immediately life-threatening problem that you may have. So a PaO2 should be greater than 10 kPa or 75 millimeters of mercury when oxygenating on room air in a normal, healthy patient. If the patient is receiving oxygen therapy, their PaO2 should be approximately 10 kPa, 75 millimeters of mercury, or less than the percent of inspired concentration FiO2. Now, that only works, just so that we can have some context here, when you're using kPa. You cannot use this formula or this indicator, if you will, if you're not using kPa or if you're using millimeters of mercury. So, give you an example. If the patient is on 40% oxygen, you expect the PaO2 to be 10 minus that in kPa, 30 kPa. And then you can calculate what 30 kPa actually means, which would be 225. So for those people looking at that going, well, that doesn't make any sense. No, it doesn't make any sense in millimeters of mercury. It only makes sense in kPa. And forgive my my shameless plugging of my app. You can just go to the app and convert kPa to millimeters of mercury and get your answer, and everybody's going to be happy. Okay, if the PaO2 is less than 10 kPa or 75 millimeters of mercury in air, on room air, a patient is considered to be hypoxemic. If the PaO2 is less than 60 millimeters of mercury on room air, a patient is considered to be severely hypoxemic and is in respiratory failure. And of course, we've discussed many times the PF ratio, PaO2 to FiO2 ratio, and what all of those things mean. And that's a whole nother, talk and trail we can take, but we're just going to keep it simple, and that's what we're going to look at here today. There are two types of respiratory failure. There's a type 1 and there's a type 2. Type 1 respiratory failure is characterized by hypoxemia, PaO2 less than 60, with normal or normal capnic or normal capnia. You have a PaCO2 of 45. So your CO2 is normal, but you are hypoxic. Type 2 respiratory failure, on the other hand, is characterized by a PaO2 of less than 8 kPa or 60 millimeters of mercury with hypercapnia or elevated PCO2 greater than 6 kPa or greater than 45 millimeters of mercury. So type 1, type 2. Difference is type 1 is an oxygenation problem with normal CO2. Type 2 is an oxygenation problem with a CO2 clearance problem or elevation. So in type 1 respiratory failure, and up on the top left, you see the oxyhemoglobin dissociation curve. On the side, the right side, you see the CO2 dissociation curve. Type 1 respiratory failure involves, as I said, hypoxemia with normal capnia. It occurs as a result of a ventilation perfusion VQ mismatch. Now remember, we've talked about this many times. You can have a VQ mismatch of the lungs. You can have a VQ mismatch of your ECMO circuit. So everything I'm telling you here, you can translate into your extracorporeal oxygenator when you're doing ECMO or even in the operating room. The volume of air flowing in and out of the lungs is not matched with the blood flow to the lung tissue. As a result, the VQ mismatch, the PO2 falls and the PCO2 rises. The rise in PCO2 rapidly triggers an increase in a patient's overall alveolar ventilation. They start hyperventilating, which corrects the PCO2, but not the PaO2. This is due to the different shapes of the CO2 and O2 dissociation curves, which I just showed you up on the top. The end result is hypoxemia with normocapnia, type 1 respiratory failure. Reduced ventilation and normal perfusion, as in pulmonary edema or bronchoconstriction, or reduced perfusion with normal ventilation, which would be the case with pulmonary emboli. Okay, all going good so far? I haven't gotten one goat. No goat yet. Type 2 respiratory failure, remember we talked about this, it's hypoxemia and hypercapnia. Type 2 respiratory failure is characterized by hypoxemia with hypercapnia. It occurs as a result of alveolar hypoventilation, which prevents the patient from being able to adequately oxygenate and eliminate CO2 from their blood. Hypoventilation can occur for a number of reasons. Increased resistance as a result of airway obstruction or decreased compliance, which we saw a lot of with decreased, very stiff lungs with COVID. Could be pneumonia, could be rib fracture, could be obesity. You know, we see this all of the time. We have a patient, they're on an Avalon catheter. We have them on VV ECMO. They are morbidly obese. They have a big, giant abdomen, and they're lying flat. And that abdomen is pushing up on their thoracic cavity, making it even smaller. And just by sitting that patient up, and sometimes it's a reverse Trendelenburg, to drop that belly down, you'll see their peak pressures on their ventilator drop significantly. And so you really have to consider all of these different reasons for why am I having resistance to my ventilation? Is it a fibrotic problem, a primary pulmonary problem from inflammatory processes? Is it an airway obstruction? Of course, there's different ways of finding all that stuff out, but that's again, a ventilator discussion, another discussion that we can have. Maybe we could play with our ventilator simulator and show those differences, I think, during one of our next presentations. I can maybe get Min to do that because he is an expert at ventilators. That much I can assure you. Hypoventilation, we discussed the different reasons that can occur: increased airway resistance, reduced compliance, Guillain-Barré, neuromuscular blockade. It's kind of wearing off, but they're still weak. Any drugs acting on the respiratory center, reducing overall ventilation, such as opiates, or just really not having the vent tuned properly. If you have a patient who is completely ventilatory dependent and also on ECMO. pH. Seemingly very small abnormalities in pH have significant and wide-spanning effects on the physiology of the human body. Not just that. So therefore, paying close attention to the pH abnormalities is very essential. But we say this a lot. We have a patient who is doing poorly. They're for whatever reason, they have a major perfusion deficit. We're giving them pressors. We're giving them neo. We're giving them norepi, we're giving them vaso, we're giving epi, and we're not seeing any real effect. And then we get our blood gas results back, and our pH is 7.12. So we slam in a bunch of bicarb, and as soon as we get the bicarb in, all those drugs start to work. Pressors and inotropes do not work well in an acidic environment. It needs some level of neutrality. So something to be aware of when you are fighting a pressure or fighting cardiac contractility, to consider what the pH may be. And to be frank with you, I mean, very little harm is going to come from giving an amp of bicarb, even if somebody actually didn't need it, but it's going to be tremendously beneficial. The risk-benefit ratio, in my view, is you're having that problem, draw the lab if you want, give the bicarb, because I can assure you you're going to need it. There's the basic acidotic, alkalotic pHs. They're relatively narrow ranges. We need to consider the driving force, however, behind the pH change. Broadly speaking, the causes can be either metabolic or respiratory, and they can be combined. They can be both. The changes in pH are caused by an imbalance in CO2, which is respiratory, or bicarb, which is metabolic. These work as buffers to keep the pH within a set range, and when there is an abnormality in either of these, the pH will be outside of the normal range. And we will normally do things ourselves in our own physiology to keep that pH within normal range, right? You see a patient who is metabolically acidotic from, let's say, diabetic ketoacidosis. What are they doing? They're trying to blow off all their CO2 to make their pH come up. So when you have an acidic situation, you'll make yourself respiratorily alkalotic in order to try and correct the metabolic acidotic derangement. As a result, when an ABG demonstrates alkalosis or acidosis, you need to then begin considering what is the driver for this abnormality by moving through what's going to be our next few steps of this lecture. So PaCO2, and I put a star right there because I want to tell you, and I mentioned this, I think, just the other day. When I get a call, or I call somebody, or somebody calls me and says, the pH is 7.19. That's good, but that's just not enough.
Right. You need some more clues.
You need a lot more clues. Actually, you really only need one other piece of information to know whether it is respiratory or metabolic. You only need one.
CO2.
That's it. PaCO2. That's why I put it on this slide. That's why I put that star there.
But it's helpful to know the bicarb as well, because you could have multiple things going on.
Clearly, yes, that's true. But keep this in mind. And this is very, very, remember what I just showed you a minute ago. If you tell me the pH is 7.19, and I say, well, that's good. What's the PCO2? And they tell me it's 38. I know full well that is purely metabolic acidosis.
But if they tell you it's 45.
But if they tell me it's 45, I can do my, let me see how I can make that go away. Okay, so we'll make it 45. 45. A 45 PCO2 should be with it being totally normal. This is just not meant to be very, very specific, but it's a really good guide.
Okay.
A 45 should be 7.35. With a 45. If 7.40 is 40, it goes the opposite direction, right? PCO2 goes up, pH goes down. Okay? So I can look at this and say that is 15 off, 20, 35, 16 off. So I can look at this and say that my base deficit on this particular blood gas is going to be somewhere around minus 12. I can give you a pretty good, I could guess what that bicarb is going to be.
By the difference.
By the difference, right. So if I say 735, then it would be 7.30, 50.
Yeah.
7.2
And you're assuming the patient...
would be 60. So I would need a PCO2 of 60. I said 14, I meant 15, the base deficit. The PCO2 would have to be 60. The pH would be 7.2 to reach this 7.19, but it's only 45. That's a 15-point difference. That's about what your base deficit's going to be.
Assuming their base deficit is normally around 0.
Correct.
Yeah.
There's that something hasn't been going on for them to have some other type of metabolic compensatory mechanism because of a chronic illness. That is true. This is not perfect, but it works.
It's clever.
It is clever. It's really good when you're on bypass, or you're just going on bypass and you're doing your case and you get a blood gas and you see this. It's for the acute change. It's just something changes, but it's acute and it's not a chronic problem. This is a very easy way to know how much bicarb you might need, how much CO2 you might need to blow off, all of that kind of stuff to achieve.
So if we could just remember 7.4 should be 40,
yes,
then you can figure everything else out.
Correct. For every point up on PCO2, you need a second decimal point, 0.01 drop in pH.
Got it.
Yeah. Yeah. Cool. I'm glad you like my little idea. It's one of my ideas.
That's a Basha idea.
But I'll never get credit for it. Don't worry. It's like anything else. Before you know it, somebody, and probably somebody we know, it will become their idea.
You have to name it something that's catchy.
Yeah, absolutely. So when you look at the PCO2 at this point, prior to assessing the CO2, you already know the pH. And remember, we talked about this earlier, you know the PaO2 because that's the thing that's going to hurt the patient the quickest. So, for example, you may know that your patient's pH is abnormal, but you don't yet know the underlying cause. It could be caused by the respiratory system, abnormal level of CO2, or metabolically driven abnormal level of bicarb. Looking at the level of CO2 quickly helps rule in or out the respiratory system as the cause of the derangement. For example, you look at the bicarb level here, and so quickly look at the PCO2. I'm sorry, PCO2 here, pH is low, PCO2 is elevated, bicarb is normal. It is purely respiratory. You have respiratory alkalosis. The pH is elevated, the PCO2 is down, but the bicarb is normal. That is going to be completely respiratory alkalotic. Whereas if you have a pH which is decreased or normal and a PCO2 that is elevated and a bicarb that is also elevated, you have a respiratory acidosis with metabolic compensation. And that's because you see the pH is relatively, if the pH is, then that amount of compensation can be more or less. And we're going to get into a little more of that moving forward. Respiratory alkalosis with metabolic compensation is characterized by an elevated or normal pH, a decrease in PCO2, and a decrease in bicarb. So you excrete more bicarb, or you reabsorb more hydrogen ions in order to try and keep the pH more normal. You don't want the pH to be really, 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 really high when you have a really low PCO2. But those are compensatory mechanisms that definitely take time. So now we all have seen this. We all know the Henderson-Hasselbalch equation. And there's a big long write-up about it here. Very sort of easily, CO2 and water form carbonic acid, and that is a reversible equation, which you see by the arrows going both directions. Bicarb and hydrogen ions form together for carbonic acid, and that's also a weak acid, which can then go over and be blown off and turn into CO2 and water. So both of these, as you see, are reversible directions so that you can adjust your CO2 level and your hydrogen ion level through your respiratory component. And that's basically the Henderson-Hasselbalch equation. The kidneys participate in this as well. So we need to ask ourselves, is the CO2, so that's all I'm going to say about the Henderson-Hasselbalch equation. Okay. Unless you have any questions.
I do not.
Okay. So we need to ask ourselves, is the CO2 normal or abnormal? Well, here it's going to be in this first example. It's going to be normal. If abnormal, which it's not, so we're going to go down to the first abnormal one. Does this abnormality fit with the current pH? In other words, if the CO2 is high, it would make sense that the pH was low. Remember my little formula. 7, if the PCO2 is 50,
the pH is low.
You expect the pH to be 7.3.
Yeah.
That's right. It would make sense pH was low, suggesting this was more likely a respiratory acidosis. If the abnormality in CO2 doesn't make sense as the cause of the pH abnormality, in other words, your 7.29, PCO2 is 35, that doesn't make sense because you would expect the pH to be 7.45, right? E.g. the number or the normal decreased CO2 and decreased pH, it would suggest that the underlying cause for the pH abnormality is metabolic. But you can have compensation. We're going to talk a little bit more about that. You have metabolic acidosis, pH is down, bicarb is down, PCO2 normal. Metabolic alkalosis, pH is up, bicarb is up, CO2 is normal. You can have a metabolic acidosis with respiratory compensation. So your pH is down, your bicarb is down, your CO2 is down because your CO2 is trying to drive, you're trying to blow all of this off in order to have more of this. And then metabolic alkalosis with respiratory compensation. So your pH is elevated, your bicarb level is elevated, and your CO2 level is also elevated because you're trying to drive the PCO2 down. So you decrease your ventilatory rate, or you decrease your tidal volume. There's going to be some respiratory response to an elevated pH in order to get the pH to come back down. So give somebody a bunch of bicarbonate, you're going to depress their respiratory drive.
They're going to slow down their breathing.
Correct. The base excess is another surrogate marker of metabolic acidosis or alkalosis. A high base indicates there's a higher than normal amount of bicarb in the blood, which may be due to primary metabolic alkalosis or a compensated respiratory acidosis. This is something we see a lot of on long-term ECMOs. Patients that have ARDS who are on ECMO for a very long time, who we're trying to do very minimal vent contribution to do vent lung protective strategy.
Right.
And we're also now accepting, and this is a very, very interesting, I think, potentially debatable topic, but some people believe that that the patient, the post-ECMO ARDS patient, is going to remain hypercapnic for the remainder of their life. And that the only way to manage that patient is to allow for metabolic compensation to take place. So rather than correcting the PCO2 to 40 on ECMO, they allow the PCO2 to continue to rise, and as long as the pH remains above either 7.29 or 7.3, whichever, either at 7.3 or 7.29 and above, to allow for the kidneys and the body's physiology to start retaining bicarb and getting your bicarb level much higher. And you'll see these patients with very high bicarb levels, 48. I've seen 48.
You're teaching the body, you're allowing the body to teach itself to how to survive.
Correct, yes. So, and that to correct that pH.
Right.
So, because acutely it can't.
Yes.
It can do it when it's a compensatory chronic problem,
right,
or a chronic problem that now has a compensatory mechanism,
because
which
it
takes
learns.
several days. Yes, but I have seen PCO2. I've seen pHs of 7.34 and a PCO2 of 90.
Yeah, we saw frequently some in the high 60s.
Yes, I think some permissive hypercapnia is fine in order to help reduce the lung trauma from the vent or the whatever it may be. I think there's that, but I'm not so sure. I didn't see good results from it, but it was a theory, and it was a good theory. It was smart. I totally get it, but I didn't see good results from allowing it to get much over 60.
Well, except that we had the worst situations to be able to try to test this out, right? These were our COVID patients at some locations, and they were very, very sick. So it'd be interesting to see this on a different type of ARDS patient, I think.
Yeah, possibly so. So a very low base excess indicates there is a lower than normal amount of bicarb in the blood, suggesting either a primary metabolic acidosis or a compensated respiratory alkalosis. So it can go both ways. So I want to touch on compensation a little bit additional for clarification. Respiratory acidosis and alkalosis changes in CO2 can be metabolically compensated by increasing or decreasing the level of bicarb in an attempt to move the pH closer to the normal range. Metabolic acidosis and alkalosis, changes in bicarb, can be compensated by the respiratory system retaining or blowing off CO2 in an attempt to move the pH in the normal range. So both of these systems are what their goal is, either way, either decreasing the level of bicarb or increasing the level or decreasing the level of CO2, is to adjust the pH. That's what's actually being adjusted or dealt with here. It's the driver, if you will. In respiratory compensation for a metabolic disorder can be immediate. It can happen very, very quickly. Okay, you can blow off CO2 really fast. Of course, we call those patients when they're doing that and they're hyperventilating. We call them, especially when they're doing it for a metabolic acidosis and not just anxiety. They're tachypnic, right? And they will eventually get very tired.
They get very sleepy.
Very tired, and they will. That's something you need to address. That's an emergency situation. Metabolic compensation for respiratory disorders, however, takes at least a few days. And I'm not going to go through the whole thing, but sort of the point that I'm trying to make to you here is that if you see something that is compensatory, you can assure yourself this has been going on for a while.
Right.
Right? So any change that appears to be that is a required metabolic compensation, not respiratory compensation, that wouldn't make sense. Anything that you see that is a metabolically compensated state, the condition of the patient has been there for at least a few days and possibly even longer. I think that's what I'm trying to convey with this particular slide. Correct. Didn't just happen. Respiratorily, however, that's a different story.
Right.
It's also important to mention that you can have mixed acidosis and alkalotic states. Such as respiratory and metabolic acidosis, respiratory and metabolic alkalosis. In these circumstances, the CO2 and the bicarb will be moving in opposite directions. For example, the CO2 is going up and the bicarb is going down. In mixed respiratory and metabolic acidosis, the CO2 going up makes the pH go down. The bicarb going down makes the pH go down. So this is a bad situation because you have two forces now driving the pH down. It's mixed acidosis. This is a mixed respiratory and metabolic acidosis.
Right.
So it's both, not one being acidosis, one being alkalosis.
And they're caused by different things, right? So you have to treat the different things?
Absolutely. Treatment is directed towards correcting each primary acid-base disturbance. So though they are both sort of being reviewed on the same sheet of paper, your blood gas, and both seemingly have the same effect on the pH, you have to take both of them and separate them and figure out why is this one doing this and why is this one doing that, and treat each one individually in order to bring things back into homeostasis. One of my favorite words. It's my word of 2022, homeostasis. Causes of acid-base disturbances. So far, we've discussed how to determine what the disturbance is, and once we have established that, we need to consider the underlying pathology that is driving whatever that disturbance may be. So respiratory acidosis is caused by inadequate alveolar ventilation, leading to CO2 retention. A respiratory acidosis would have the following characteristics: decreased pH, increased CO2. Now that is caused by inadequate alveolar ventilation. It's also caused by inadequate sweep gas across our oxygenators, whether it be on cardiopulmonary bypass or ECMO. In fact, it is really interesting that you can have, and Tammy, you have firsthand experience with this, I do too, you can have a PO2 on bypass of 300 and a PCO2 of 120.
Yeah.
And you're sitting there going, what the heck is going on? Not the valve, they're not using CO2 flush. This is just a regular coronary case.
Yeah, this is on bypass.
Standard cabbage.
Yeah.
And you turn your sweep gas up and the PCO2 stays well over 100. But your PO2 is great. You find a leak.
It's not an oxygenator problem.
Not an oxygenator. You have very low sweep gas.
Yeah.
So if you remember the graphs I showed you,
of sweep gas.
You're right. Your O2 transfer is much easier and much faster, whether it be in the lung or whether it be in the artificial lung, than is your CO2 transfer. We know that, right? This is something we all know. Yeah. So a sweep of 0.5 liters going through your ECMO will give you a pretty good PO2, but your PCO2 is going to be through the roof. So it works both ways, whether it be...
Since we brought it up, do you want to go ahead and talk about where that leak is likely occurring?
No, you can.
So if you ever see that on bypass, because I went many, many years without ever seeing that, it's likely you have a leak related to your anesthetic gas vaporizer. You have a crack in your line, or something, and it can be
Or the cap's not on.
or the cap
Or loose, or not secured, or
it's not locked.
not locked.
Right. Mine in particular was a very, very small crack in the connector of where the sweep gas went in and out of the vaporizer. So, and it was something that you really couldn't hear escaping necessarily unless you were looking
We
for
had to
it.
clamp the line and turn the gas way, way up just to hear it. We found it, but
Yeah,
it took
we
us a
found
while.
it, but it took us a minute. So quickest thing to do if you ever see that is go straight to an oxygen tank or isolate out your vaporizer and just
Yes.
blow in 100% oxygen on from your pump.
Yes, absolutely. And I wanted to keep mentioning things because I wanted to bring somebody up here who
Okay.
has a really cool tool. I don't know if you remember or not. I'm looking for his name. I don't know why I always blank on his name. My buddy up in
that
Cleveland.
he has the
That wheel that goes, Amit.
Yeah.
The Amit wheel.
Yeah.
That goes around and that you can actually see the flow, and you would really be able, I think, to appreciate that loss. You would see it slower.
Yeah.
So you would probably be able to find a leak a little bit easier. I showed a video of it one time on one of our programs. It's really cool.
It's very cool. And one thing you could do pre-bypass to check for that, because you're likely not going to have made the small crack or your tubing has not suddenly become hard and cracking because it's old on your bypass run, is
Right.
to go ahead and clamp your O2 line into your oxygenator while you have your sweep gas and your vaporizer on, and you should see that your sweep gas goes down to nearly zero.
Yes.
Because,
Should.
Yes, because then you're testing to see, does it have any other way to get out?
Yeah, but
right?
don't turn it on 10 liters and do
No,
it.
that's
Just put
too
it
much.
on 2 or 3.
2 or 3 liters.
It'll go to 0. It'll drop to 0.
Yeah,
You
and
take
it's
it off,
it's
and
a slow
you'll
drop.
feel that pressure.
But that's a pre-bypass thing that you could do to go ahead and check the integrity of that system.
Absolutely. I do that too. I do that still to this day. In fact, I take it off and I still breathe the gas.
Oh,
but
yeah.
I always make sure I do it distal to the
filter. Yeah, it needs
because
to be
that filter
distal.
can crack as well.
Yeah, it needs to be distal to your filter. It needs to be right before your oxygenator.
Yes. Well, you can
Correct.
just take it off and put your finger over the hole.
Yeah, you can do that. And I have seen it as well where the vaporizer itself was needing calibration at some point, and it had some sort of internal thing where it
Yeah.
wasn't locking down properly.
Yeah, the vaporizer was malfunctioning. Well, I mean, one time I didn't do that. I didn't do what I normally do. I skipped a step. Usually nothing ever goes right when you do that.
Nothing goes right when you do
And
that.
I went on bypass. I opened the venous line up and I opened the arterial line up, and I didn't even wait. Like, it happened immediately, and I realized I haven't hooked my gas lines up yet. And so
You had some black blood.
no, I never did.
Oh.
The crystalloid was still coming down when I realized
that was
it,
very
and I
fast.
got it connected really fast. Of course, you hear the alarm go off, and of course, the chair that I had went flying across the room and
hit the wall.
Yeah, I think I slipped and fell once or twice. Got it all connected, and everybody's like, "Is everything okay?" And I walked back to the pump, and I was like, "Blood's red, looks good. We're on pump. You want to clamp?" Like that.
That's the kind of thing that takes years of experience to learn how to problem solve, maybe make a little noise, but then be completely calm and let everyone know everything's fine.
Yeah, exactly.
Everything's fine now.
Yeah. Are you okay? We're cooling. Okay. Causes of respiratory acidosis include respiratory depression from opiates or whatever, Guillain-Barré, paralysis, of course, leads to decreased ventilation, inability to adequately ventilate with asthma, chronic obstructive or COPD, iatrogenic, incorrect mechanical ventilation settings. You can have ventilators leak. You can have ET tubes leak. You can have balloon leaks in the ET tube. There's all kinds of things that can cause that problem. So a respiratory acidosis, all that tells you is that there's inadequate alveolar or oxygenator ventilation. That's a very important difference, because we're not talking about hypoxia here. We're talking about respiratory acidosis. Different.
Yes.
Respiratory alkalosis, on the other hand, you have a reduced PaCO2 and an increase in pH. Characterized by that, causes anxiety, panic attack, hyperventilation, pain. You have an ECMO patient who has high anxiety, is uncomfortable, over-breathing the vent, doing all those things that can affect your blood gases. Of course, also, if they're very, very, very tenuous, that extra movement can sometimes even cause your O2 consumption to go up sufficiently. And if they're right on the edge, you do start to end up hypoxic, which then exacerbates the anxiety. And it's,
they can't catch their breath.
Yeah, making people comfortable is really tough when you're trying to wake them up so that you can ambulate them. And,
we saw a lot of that. It was like watching someone be just in agony.
Yes, absolutely. Yeah, exactly. Hypoxia, obviously, resulting in increased alveolar ventilation, an attempt to compensate. Pulmonary embolism, pneumothorax. That's something we saw a lot of, even on mechanical ventilation with pneumothorax. Now, a pneumothorax without mechanical ventilation is one presentation. On mechanical ventilation, it's a totally different presentation and can be very severe, very extreme. And obviously it can be iatrogenic, meaning that we are causing it by excessive mechanical ventilation. Metabolic acidosis can occur as a result of either increased acid production or acid ingestion, decreased acid excretion, or rate of gastrointestinal and renal bicarb loss. So either of those two things. A metabolic acidosis would have the following characteristics on a blood gas: decreased pH, decreased bicarb, and the concurrent or concomitant decrease in base excess, which would be a base deficit. Right?
Base deficit, right.
Metabolic alkalosis occurs as a result of decreased, John did a program on this, decreased hydrogen ion concentration leading to increased bicarbonate, or alternately, a direct result of increased bicarbonate concentrations. A metabolic alkalosis is characterized by increased pH, increased bicarb, increased base excess, so it goes the exact opposite way. Acidosis, decreased pH, decreased bicarb, and a base deficit. Alkalosis, increase on all three. Causes of metabolic alkalosis include the gastrointestinal loss of hydrogen ions from, let's say, vomiting or diarrhea, renal loss of hydrogen ions when you're using loop,
diuretics,
and any loop diuretic or hydrochlorothiazide or HCTZ diuretics, heart failure, nephrotic syndrome, cirrhosis, and Conn syndrome.
What is
I had to
Conn
look
syndrome?
it up. It's some kind of abnormal secretion of aldosterone or something like aldosterone.
Okay.
Yeah, I didn't know what it was either. I looked it up, but it's not something we're going to have much involvement with, but it was there. And then, of course, you can have iatrogenic, which we talked about, which is giving the patient too much bicarb. And a lot of times, when we do these cases, we're using CRRT.
Yep.
And a lot of the bags have bicarbs of 32, which is higher than what is normal, right? 24 is more normal.
So you have to be careful about the fluid selection.
Well, yeah, you can get bicarbs of 30, 32, and even 35. So you do tend to start seeing over time that metabolic alkalotic effect from high volume CRRT. You can see that. But if the patient is struggling with either bicarb production or clearance of hydrogen ions, sometimes you see nothing. You really need that elevated bicarb level. But the beauty of it is it's a bicarb based fluid, not sodium based, and far superior than a sodium bicarb drip, where you have to then be concerned
about the
about
sodium.
hypernatremia, which
Right.
is not uncommon either of these cases. Anion gap, I'm going to, in the interest of time, I'm going to skip it. It's interesting, it's academic, but it is, I don't know how germane it is to us. The formula is the sodium minus the chloride plus HCO3. So
Right.
take chloride and HCO3 and subtract it from sodium, and that's your
think
anion
that's-
gap.
I mean,
somewhere normals between 4 and 12.
Yeah, I was going to say that's for most basic knowledge. That's really all you need.
Yeah, I'm going to keep it simple. People can read it if they'd like to and go through it. We can have mixed respiratory and metabolic acidosis. Obviously, that is a big problem when you have both. Decreased pH, increased PCO2, decreased bicarb. It's cardiac arrest, multi-organ failure, big problem. And you can have mixed respiratory and metabolic alkalosis. I'm going to get right to the quiz. And I got to thank
quiz?
Liz. Yes, quizzes.
Pop quiz.
I'm going to thank Liz. Pop quiz. Thank Liz Potter for this. Quiz 1. PaO2 is 53, pH 7.29, PCO2 68, bicarb 26, base excess plus 1. What is the problem?
Why did you make the print so small?
Can you make it bigger?
That's you. That's your presentation.
Oh, is there anything I can do to make it bigger?
No, that one's better, but it's okay. Let's just get through it. Okay, so we've got 53,
sorry.
7.29, 68, 26, and plus 1. 53.
So we know the PO2's
Yeah.
is okay.
It's
53.
okay. Yep.
pH is acidotic. PCO2 is elevated. Bicarb is normal. So we know it's not a chronic problem. So it's an acute problem. So it's acute respiratory
Respiratory
acidosis.
acidosis.
Correct. Exactly. Okay, hopefully this one's better.
Yeah, that one's bigger.
Okay.
Okay.
This one, your PaO2 is 68, so the patient's not immediately dying. pH is 7.3. PCO2 is 63. Bicarb is 29. And you have a base of 3. Now, just remember what I had mentioned before. What happened?
Oh, you went to the wrong quiz.
That's
Okay.
fine. 7.3. I expect with a 7.3, the PCO2 to be 60,
Yeah,
right?
60, right?
But because the PCO2 is 63, then I expect the pH to be 7.2, right? 7.4. Yeah, 7.2.
7?
Yeah, 7.23.
Yeah, okay.
We'll say. But it's 7.3. So the PCO2, the pH is acidotic, but less acidotic than I anticipated it
So
to be.
you should have metabolic alkalosis with partial respiratory compensation?
Close. The PCO2 is elevated, so I know it's respiratory acidosis. My primary problem here, I know, is respiratory acidosis.
So it's the opposite, really, with partial metabolic compensation.
Correct.
Right.
You get a prize on that one. Good one. Okay. Quiz 3. PaO2 is 93. This patient's oxygenating great. pH is 7.29, so that is a little acidotic. But the PCO2 is 41. That's normal.
So we should have
So
a pH
we have- I'm gonna-
around 7.4.
Let me reverse this. I'm going to put down. I'm going to put an arrow down. I'm going to put that's normal. Our bicarb is only 15. That's down. And our base is slightly decreased. Okay? So with a decreased pH and a normal PCO2, it's not respiratory because my PCO2 is normal.
Right, so it's got to be metabolic acidosis.
Correct. Metabolic acidosis. Exactly. Very good. Quiz 4. PO2 98. pH is acidotic. Down. PCO2 is 26. That's also down. Bicarb is down. The base is not that low, but there's a reason for that, which we can discuss. So my pH is low. It's acidosis. My PCO2 is low. My pH should be very high.
Right.
My bicarb is very low. So I know this PCO2 should reflect metabolic alkalosis, but I am still acidotic. The 13 bicarb means I'm metabolically acidotic. So would it be respiratory acidosis? Clearly not.
No.
Metabolic acidosis with partial respiratory compensation? Well, it's metabolically acidotic, and the PCO2 is low, and my base deficit is not nearly as low as I would expect the bicarb to be. So this is a possibility. I'm going to put a question mark right now. Metabolic acidosis? Well, yeah, there is a metabolic acidosis. This patient is metabolically acidotic, but there's something else.
There's something else for sure.
Respiratory acidosis with partial metabolic compensation? Can't be. The patient's not at respiratory acidotic. Respiratory alkalosis with metabolic compensation? Now that could be a question mark. And metabolic alkalosis, which it's not metabolically alkalosis, with
acidotic.
Respiratory compensation.
Okay, so it's either 2 or 3.
Well, no. It
2 or 5, right?
Could be metabolic. No, it's not metabolic alkalosis, metabolic acidosis.
Yeah,
so this goes out.
It's 2 or 5.
So it's 2 or 5. Which is it?
2 or 5. Respiratory alkalosis. So I think it's 2.
You think it's 2?
Yeah, right? Metabolic acidosis with respiratory compensation. No. Yes, that's what I think it is.
You are correct.
Yeah, because the PCO2 is low. So that's the clue.
That is the clue. And you are correct. This is the last one.
Okay.
PO2 is 71. pH is 7.14. PCO2 is 60. Bicarb is 15. Base is -9. That's what you would expect, right? Mixed respiratory. So what is our problem here? Do we have mixed respiratory and metabolic acidosis? Well, we have a respiratory acidosis.
Yep.
And we have a metabolic acidosis for
Yep.
sure. So this is a possible. Do we have respiratory alkalosis?
No.
Do we have metabolic
No.
alkalosis? No.
We do not
Is
have
it normal?
No.
Hell no. Metabolic acidosis? We do have metabolic acidosis, and we do have respiratory acidosis.
It has to be one.
It is number 1, mixed. Very good. We get to spin the wheel for you.
For me?
You did good. You never get the wheel spun for you, and I'm going to spin it.
All right.
Okay. You get a prize today.
Please don't give me extra call.
Can I get a goat? Can I get a goat, please?
Oh, a real goat? Yeah.
He's got it right there.
Thanks.
Okay. Here we go. You ready? Let's do this.
Okay.
I'm going to kind of pick a different spot for it.
If you give me aortic dissection, my afternoon surgeon's going to be very mad at you.
Here we go. What is Tammy going to win today?
Come on, Amazon.
Amazon gift
Yes!
card. Yes. Good job. Okay. We'll see you all.
Next week, we've got Tuesday.
Is it next week?
Yes, Tuesday,
No,
8
it can't
a.m.
be next week.
It is.
It can't be next week.
It is. It's Tuesday, 8 a.m. We've got Journal Club, and we will be talking about the inflammatory process in air, I believe.
Yes, and biocompatibility. Air, inflammation, and biocompatibility, followed by John Ingram,
Yep.
urine output on CPB.
That'll be
When is
Wednesday
enough?
at 1500, and then
I have a talk on Thursday, 8 a.m., same time,
Yep.
on does ultrafiltration reduce urine output on CPB? What is the evidence?
yep. So-
Okay, very good, because I hear people say all the time, oh, don't ultrafiltrate, it'll reduce urine output. Okay, so I don't want to bias what I think, okay, or what my data tells me, or what the data says. Everyone is entitled to be wrong.
Leave it to next week.
Leave it to next week.
Thank you for joining us this morning. Please join us for PerfWeb 78, and have a great rest of your week.
Bye. Okay.